Gero Nurses, Tales from the Front, is made possible thanks to support from the Center for Education and Research on Aging at the University of the Fraser Valley and the Gerontological Nurses Association of British Columbia.
Welcome back to another episode of Gero Nurses. In this episode, Shelley and Lillian talk to the past president of the Canadian Gerontological Nurses Association, Dr. Laurie Schindel-Martin. Enjoy.
All right. Greetings and thank you for joining us, Laurie, and all the audience. I'm Lillian Hung, the podcast co-host, a Gero nurse who loves working with older people, a friend of Shelley and Laurie, and I teach at UBC in the School of Nursing. Over to you, Shelley.
Hi, I'm Shelley Canning, and I also teach nursing, but at the University of the Fraser Valley, and I am the current president of the Gero Nurses Association of BC.
And this is Gero Nurse, Tales from the Front, where we want to share inspirational, fun, real life, some of them are secretive, compelling stories of Gero nurses.
And today we're really excited to have Dr. Laurie Schindel-Martin as our guest for this episode. Laurie is a Professor Emeritus at Toronto Metropolitan University, and she's the immediate past president of the Canadian Gerontological Nurses Association. Laurie has been committed to developing curriculum and competency standards to support nurses in caring for people living with dementia. She was the lead curriculum developer for the Gentle Persuasive Approaches program, and more recently, she's been a member of a working group developing e-learning modules focused on sexual expression in dementia.
So hi, Laurie. Thank you so much for joining us and taking the time. And can you start telling us about what brought you into the field of Gero nursing?
Absolutely, Lillian. I'm delighted to be able to provide that background. And thank you very much for inviting me to talk with you today on this wonderful podcast. So first of all, I would say that I grew up in a small community named Beamsville, which is in the Niagara Peninsula in Ontario. And really a community at the time where everybody knew each other, and all the older people in the community were seen as icons and leaders and wise people who had lots to share. And you could be a little kid, 6 years old, sent with money in a little wallet down to the grocery store to get a jug of milk, and you would pass many older people within that community. And it was always fascinating to me. I loved to hear their stories, and they would always share stories about what it was like for them when they were growing up within that town. And so it was the narrative that always appealed to me. My mom was a nurse, and she encouraged me to consider nursing as a career. And fast forward into being at the School of Nursing at McMaster University, I can recall an assignment. I don't know whether you would remember, but there used to be these assignments that were critical conversation analyses that you had to engage in a conversation with someone and then analyze whether you were being a positive person in terms of your communication, affect, tone, questions, and analyze your dialogue. Well, I chose to do mine with Auntie Violet, who lived next door, was not a relative, but I just loved that exercise and asking her questions about what life was like where she grew up. I will also say that many of the homes, because I was born in the 50s and grew up mainly in the 50s, that many intergenerational families was part of the landscape because people couldn't afford to have their own house, and grandparents were often living there in folks' homes. My next experience in first year was I was assigned to a long-term care home. Most of us in that class were, and that continued to be a practice in the School of Nursing. And I still remember Mike, the man that I was assigned to work with. And I just thought, this is something that really interests me. And this gentleman happened to be the daughter-in-law of the director of nursing at the long-term care home. And the stories he told were just amazing about the sorts of things that he did with his career, the countries he had visited, and how he was feeling somewhat ashamed that he could no longer act out these things. And I remember his daughter-in-law, the director of nursing, coming into the room and joining our conversation. And the commendations she gave back were amazing. They reinforced his true self and his memories. And afterwards, out in the hallway, she explained to me how this is not, we love our older people. It was respectful and purposeful memory and reminiscence therapy. And I was gobsmacked because I've heard nothing about stuff like this in the conversations from my professors in the School of Nursing. So from that day, I knew I wanted to work with older people, and I had to push against lots of folks telling me that this would be a big mistake for me to do that. That older people, like, why? No, that the best thing is the heavy technology. That's what makes nurses exceptionally good at their jobs. And I never accepted that. I never took that to heart. I never embraced that philosophy. And throughout my career, I've worked with older people.
So that tension is still there.
Oh, yeah.
That pushback all these years later, that bar hasn't moved very far. So any new nurse who thinks, I would love to have a career focused on gerontological nursing will get that same pushback.
Unless they have the luxury, my dear colleagues, of meeting up with one of us or others across Canada who are passionate gerontological nursing and vocally and disruptively challenge the existing narrative, and that is nurses are technicians, which and that's what makes us nurses. I think that there's some of our colleagues, yes, who have strong grounding in gerontological nursing practice. I always delight when there are new faculty members who are hired who have that background, because it is just totally wonderful to be able to collaborate within the school. Within my cohort at Toronto Metropolitan University, previously Ryerson, there are several of us. Dr. Christine Newman, who is a member of the Canadian Gerontological Nursing Association and involved with the Ontario Gerontological Association. Sue Bookie Bassett, Dr. Daria Romaniuk, who is the chair of our undergraduate baccalaureate program. And that is always wonderful to be able to have someone like that knock on my office door and say, can we have a conversation about embedding gentle persuasive approaches into our curriculum? Where would that go? And what would that look like? And what are you thinking? Because I've got an idea of where this could go. So that kind of thing is really wonderful. And one of my dreams would be that there's some kind of education cooperative across our pan-Canadian, where we share the resources that we've developed. Lillian, I'm thinking of that wonderful videotape that you shared with us at Gentle Persuasive Approaches, where it showed somebody walking to the exit of a unit. And yeah, like that sort of stuff we need to share with each other. And Shelley, I've always been interested, as with you, Lillian, the work that you do in your own programs of research and what I can embed in a fourth year policy course for senior nursing students so they understand how exciting gerontological nursing and persistent chronic illness nursing can be.
So, Laurie, you talked about like you storytelling, and you mentioned about like you love hearing the narratives, and older people are wise, and they have lots of stories to tell. And you mentioned about sharing and conversation with other colleagues. Like, why those conversations, like listening to people's stories, are important for human experience? And why are they exciting?
I find them exciting. On multiple planes. You can take a systematic admission history in long-term care or complex continuing care or acute care for that matter. And then you hear a story from somebody through an informal chit chat, conversation, informal sit down, and that therein is where you find the information, because that's just not going to come out of a formal assessment. What kind of a questionnaire is this in? So the best that I found is sort of like the work by McCormick and McCants, where they say when you're speaking with somebody, even students and student nurses for that matter, when I think of this case, I see, I hear, I imagine, so that you can actually, like we used to say, enter the person with dementia's world. Well, what exactly does that mean? The more we work together, the more we figure out how to operationalize that. So I used to ask those kinds of questions. Okay, so here's a little story. A lovely woman, a beacon of her organization, lovely, iconic, historical person, develops dementia to the extent that she can no longer live at home. And she engaged in what is often called repetitive vocalization. Help, 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 help. And she also was perpetually investigating her environment. Not necessarily, and we used to call that stuff exit seeking. Oh, for goodness sake. No, she's exploring the environment, and maybe she wants to find a way to the familiar, her house. Okay. So, or maybe she's looking for the toilet, because a couple of times my office was right on the unit. I would find a nice little stool with some toilet paper on my office chair, because my door was never locked, and often it was open with something keeping it open so people could come in and talk to me. Okay, so I could get furious with that and go, how disgusting is this? This is a hygiene problem. And I just always started to go to sit down beside her when she was going, help, help, help. And I would say, so, you're sitting in this neighborhood and you're calling for help, and you're calling to others even when I'm sitting here talking with you. And she just looked at me and she said, it's because I'm sitting here and I see everyone busy and they're going about their stuff, and surely there's something I could do, which isn't like, it's not help me, it's like, I could help you guys. Isn't there anything you could do? And and when I had a conversation, I decided, instead of locking my office door, she's looking for the familiar. She's looking for the toilet. She can't find the toilet. Let me invite her into my room, my office often, So she recognizes it as something other than a toilet. My chair is not a toilet, right? Okay, so it worked. And what I did was brought her in, sat her down, and we sat in two chairs side by side. We had coffee together, and I said to her, when you look at this room, what do you see? And she says to me, why, it's a little library, dear. And I always wanted to be a librarian, don't you know? And like, how would you ever get that info if you didn't just sit down with people and have conversations? So that's one example. That was so useful because then we developed all kinds of librarian-oriented activities for her to do that would draw her away from extensive, expanded moments of help. And
is sorry, Lori, great example. I absolutely love it. It's just the humanity of it that comes through for me. You're just addressing her in the most human, caring, calm, and really trying to figure her out, not going into the interaction having already decided this is the event that's happened, this is how we deal with that, and away we go and on to the next thing.
Yes. And so the stories I could tell you are you know, a woman that and often it's that question of what does this mean? Tell me more about this. So two women I can think of, a woman who continuously repeated, haven't got a pot to piss in, haven't got a pot to piss in, haven't got a goddamn pot to piss in. And I just said, you know, why don't we ask her? A couple of us should go in and have a chit chat and just go, tell me about what was it like for you when you were growing up? Did you sometimes say, haven't got a pot to piss in? Did you hear your folks say that? Like, tell us about this. And so her experience of the Depression, and sometimes only having potatoes to eat that they dipped in lard around the table, 12 family members, that also says a lot and explains why the person feels compelled to find bits of food, wrap them in a napkin, and put them in her side drawer, and will get upset if the cleaning staff come in and dump it out. And say, don't do this. It's against infection control. That's that. So the humanity, and I think that you know, what do you see? What do you feel? What do you hear? What do you imagine? Are just questions that. And how come, guys? These kinds of very easy questions, like where's that? We don't embed this stuff in. You try to do it, Shelley and Lillian, into curricula and introduce it, but then how do you do that on a continue at the end of every class? Do you go, okay, so after today's class, what do you see, what do you feel, what do you hear, what do you imagine? And you ask them to do what, like every second week, 150 word reflection, and then they look back on that someday and go, wow, I really, you know, like, I don't even know how to do this in a consistent way other than just total experimentation all the time. And it changes from course to course, from cohort to cohort, because there are often unique cultures to the class, right? You could still have 200 students sitting in a class, or, you know, a group of 12 new hires that you are onboarding, that the overriding message is nothing can be done, or something like that, or anything. The possibilities are endless. It's so cool.
Do you find, though, your stories are a really good way to reach your students? Because I think nursing uses storytelling and our experience as clinicians our ability to share that just in the way you just shared your very real, true stories. It's not a scenario in a textbook. It's actually your truth that you've lived and you've done those things.
Right.
I think there's such power in that.
I do, Shelley. I do, Lillian. And I think the dilemma is that unique, exceptional courage that nursing faculty must have, and that some of the more vocal students who understandably are so wanting to pass the NCLEX and that final exam, and they are not interested in the narrative as much as they are interested in learning, will items like this be on the NCLEX exam, and or on an examination or an evaluative, a cumulative evaluative thingamabobber for this course. And we appreciate that you gerontologized this fourth year course. We really appreciate that. But really, how many of us are going to be working with older people? And come on, like I already, this three person teaching team, every class we keep saying that only a very small number of you are going to enter the pediatric system and get working at sick kids in like you the majority of you will actually be working with people probably over the age of 55 who have multiple complex synergistic comorbidities, and you will need to understand these kinds of things and listen to the stories that underlie their lived experience. So I've always sort of read my faculty evaluation surveys with the idea that what is my goal as a gerontological nurse who is an educator, researcher, scholar? My goal, I suppose, is to maybe bring more onto what they might think of as the dark side, working with older people, but I think it's the enlightened side, versus those who are already there, early adopters. I'm going to do everything I can to strengthen their resolve to continue in that kind of way. And when people say stuff like, this professor needs to know that they should not be forcing gerontological content down our throats. And when I see that, I become very sad and distressed. But I have taught myself to just set it aside, to not take it personally, and rejoice in those who kind of go, oh, this is very intriguing.
You talk a little bit about the dark side of gero nursing. What do you think the young nurses are like, or students are afraid of, or like find it not interesting in gero nursing?
I think that what contributes to their overall feeling of distress is moral injury, where they have someone like me saying these are things that are possible, these are things you could put in place, and then they get into the real world of a clinical practicum, for example, in their fourth year, and they could have the luxury of being appointed to a teaching nursing home.
Yeah.
There are many in Ontario that are affiliated with the Centers for Learning, Research and Innovation, for example, and other social service enterprise, not-for-profit homes that are very wonderful and do an excellent job of having multiple integrated theoretical frameworks that guide their practice. Paris framework sort of thinking, evidence-informed practice, well-trained, supported staff at the front line, point of care, with facilitators who are right in-house with master's degrees that can, in the moment, reinforce and commend people for their best practice and recognize that as not a happy accident, but purposeful. Unfortunately, if you happen to get appointed or assigned to a facility that, for a variety of reasons, may not have all of those elements in place, then your experience is not necessarily going to be as good as it could be. And of course, when you're a novice practitioner and there's no light shining to help you move forward in a positive direction, and I would like to say that this is so multifactorial, including the federal government's viewpoint that Health Standards Organization standards for long-term care are voluntary. They're voluntary. So what does that mean? The best homes are early adopters, and they meet those standards, and they will be eagerly looking at those standards and knowing where they need to move forward to improve even further, right? And then there are those that they're voluntary. I do not need to even open that document. And thanks for letting me know it exists, but I'll put that on my desk for later. And so those are I think that's the difficulty, is that we don't really have a system in which gerontological clinical placements are scored, shall we say, that in order to get this next generation of people really engaging in this kind of nursing and see it as entry to practice skills. Yes, it's a specialty, but really from an entry to practice perspective, there are many standards that schools of nursing are expected that their graduates should know and be able to execute well at the time of entering their career as a novice with working with older people. So I think so for example, in the policy course that I finished teaching in December of 2022, this past year, several students chose gerontological nursing standards from CASN and CGNA, and made a comment that why are schools of nursing not expected to gain a top level of accreditation for 7 years, that they have to have a robust gerontological nursing content, because otherwise this stuff doesn't mean anything, does it really? And so and with asking those questions and having a policy course that does focus specifically on the care of older persons, I think our progress will be slow and continue to be slow. And the last thing I'll say is that in our fifth week of this course, we looked at standards, and we looked at ageism as well. And when they heard the World Health Organization statistics that 1 in 2 people is ageist globally, one student said, that means if I consider myself anti-ageist, if I look to my right and to my left, those people are ageist. Oh my God, this is unacceptable, given the growing number of older people. And wondered again, why haven't I received any specific education before 4th year on even, ageism and its impact on healthcare? That's always puzzling to me, and I don't have a good answer to that, other than you keep asking for these things, and till I die, my breath will be
not okay. That's
trying to help people, with this topic.
Yeah, this is not okay. We got to do something. Like Canada's going to turn into a super aging society. We're going to have older people everywhere, and we're all becoming older people. We're all aging.
And that's a good thing, really, Lillian, is it not? because there's so many experiences. I mean, when you look at even like the pandemic and people who survived during TB and lived in iron lungs as young kids and now are older, they can go, yeah, pandemics and these kinds of very virulent and bad outcome diseases, we've lived through this before. And it will be okay. And there's always something that comes out of this and that's the advice I would give you guys. Look at me. You know, I'm able to ambulate with a limp, and yes, I have a disfigured spine, but I got married. I had a good career. You know, like life is okay. Things aren't always the total bad picture.
It's about, you said a couple of things, and I know from your role on CGNA that whether you see yourself as an activist, you are a Gero activist. It's just your passion, your straightforwardness. You don't mince words, Lori. When you see what needs to be done, you say it. How do we build that kind of, whether it's bravery or activism, so that we don't kind of get lost and just stay status quo? Like Lillian just said, Canada is an aging country. We're all working in aging communities, and we need to be able to function and to function well.
Yes.
And as nurses, you know, we have an obligation.
Yeah. Well, I think I don't know what to say other than a consistent belief that my father-in-law just gave me, because I retired, an old edition of Bartlett's famous quotations or something. It's totally amazing, because you can go through there and go, oh, for goodness sake, I never knew this thing came from this poem, this saying that was first published in 1780 or something like that. So I'm just saying, you know, there are colloquialisms and sayings that come from life experience that just resonates. And so, you know, never doubt that you could say one sentence, and if one student hears it and it makes a difference to how they act, respond, or listen, and say something like, oh, Mr. Stanley, I'm imagining that event must have been life-changing for you. Tell me about that. And I've had students come up and say that they've been working with a trans older adult who's living in the community and does not want to go into a long-term care home and is not sure what they're going to do, and saying things like, I imagine that experience you've told me about that happened in 1972, is that impacting on why you're so reluctant to enter long-term care? Are you? And yes, I don't want to have to experience that again. I've already experienced that. What am I supposed to do? So that's the kind of thing that I really do think that kind of hopefulness is what sustains me. That even one person getting a message that might strengthen their resolve, that they are not going to allow. They're not going to stand for this. And so I will just say again that one of the stories I often tell is a gentleman who was a bus operator for Hamilton Transit Commission, or I don't remember what it's called, HTC or something like that. Okay. So he drove buses, and he developed cognitive impairment, was admitted to an organization that had 3 specialty behavioral units back in the day. And when I first met him, he was around stage 7C of the Reisberg disease progression scale. And he was on 1 milligram of haloperidol with 1 milligram of Ativan intramuscularly TID. And I said, why is this gentleman, his name was Fabio, okay? And they said 4 years ago, he came out of his room and he had ripped the toilet bowl off the wall. He threw it down into the hallway because it was making noise. It was continually filling, and so he ripped it off the wall, carried it out, dumped it on the hallway, and there were at that time a few ladies who kept stripping their shoes and socks off all the time. And one lady happened to be walking by. The toilet bowl missed her feet by about 6 inches, and he was put on haloperidol 3 milligrams a day with 3 milligrams of Ativan mixed in the same syringe. And it was now 4 years later, unacceptable. And it was a lot of work that's where the BSO dementia observation system started. I created a sheet, a 30-minute observation sheet, I called it. And people had to put in a number. What's he doing? The poor man, he was so sedated, unappropriately sedated. At this level of the progression of his illness, and nobody had done any kind of reconciliation of his medications from this is just like, I'm afraid that the same kind of thing probably still does occur from time to time in places. I suspect it does, but they did not want to reduce the dose, and I said, we will do it so slowly that honestly, and I had to go to the most responsible family physician, who was kind of a little bit miffed because the idea of advanced practice nurses was not something that he thought was a good idea in gerontology. But they humored me, and we got to really trust each other. And that guy was not on anything after 4 months. And he actually was not drooling, and they were able to feed him much easier. And he actually was able to open his eyes and smile at his family. And I was just like, oh my God, these are the kinds of things that you go away and you vomit when you get home. And because people are so mad at you for wanting to challenge their practice. But I also understand that, right? Because people don't want to even begin to conceive of the fact that they were sedating people unnecessarily. That's tragic. People don't want that on their conscience, right? And I think that's the other piece, that lots of staff who don't have this kind of education and then end up suddenly, I've had this experience several times where beloved colleagues transfer in from the emergency department or an ICU or CCU or something and say, have I got a load of skills to help you guys improve with your long-term care home care delivery? But they're gobsmacked to see the sort of level of competence and expertise that the staff around them actually do have, and that they also have a lot to learn. Right?
So, Laurie, you're here. We got to talk about GPA, and you've been working, leading the field. This is the dark side of the gerontological nursing. It's the scariest part that people always worry about. Those, and afraid of those behaviors, and seeing people put on antipsychotics. The damage and the impact. So how did you gather the people to develop the gentle persuasive approach? And like, what are some of the impact that you have seen that the program has done for the folks that you serve?
Well, I think that's an excellent question, and I think sometimes all of the elements are there in their raw form, and so the hard work comes from the collaboration and moving together. So I would say that interestingly, there was a geriatric psychiatry outreach team in the area that I was consulting in. My first advanced practice job in specific to gerontology was at St. Peter's Hospital, where it was a regional referral center for the 23 long-term care homes in the Hamilton-Wentworth area. And so there was a whole consortium of people who were devoted to gerontology, and the McLaughlin Foundation gave a huge amount of money to the University of Toronto and McMaster University to develop expertise in the area of geriatrics. So there were 2 geriatric psychiatrists, a geriatrician, 3 clinical nurse specialists, myself, Fran Warbeck, and Dawn Prentice. Dawn is now the editor-in-chief for CGNA's peer-reviewed journal, Perspectives, and I would have to say that our paths, all of our paths across Canada, Lillian and Shelley, keep crossing over and over and over again, which I think is really quite amazing. I think Canada is quite lucky in that regard, and there seems to be a culture of sharing and so on. So I think there was a whole crew that got funding through the Educational Center for Aging and Health, ECHA, and Regional Geriatric Program Central, that myself, Sherry Dupuis from University of Waterloo, the Murray Alzheimer Research and Education Program, we all knew each other. We sat down together, we wrote a grant, we got the moolah. It was only like $15,000. It wasn't much. And everybody committed to work off desk, weekends, evenings, because we could see that we no longer wanted to speak about responsive behavior, personal expressions, using the terms aggression, violence, attack, unsafe, he's going to kill somebody someday kind of language that was all negative and contributing highly to the misuse and abuse of both physical and chemical restraint in the dementia context. And all of us were working at it from our own disciplines, and we were able to come together. Occupational therapy, physical therapy, everybody was there around the table. And we had big teams, one evaluation team, one implementation team, one marketing education team, one content team, and a few people spread across all of those, and then a group of executive leaders, and it worked. And we got further money to do a pilot. And then it just went from there. We chose to do a social service enterprise model, that any revenue from affordable materials would go immediately back into reserves that we would be able to eventually hire more staff and develop more products, which now includes GPA bathing. And so that's very exciting. And I would have to say, I keep wishing that we as gerontological nurses had more of an entrepreneurial spirit, because guys, I don't know what you think, but my experience is once you create something and let your big organizational boss take over that and then decide they're going to sell it for some kind of purposes, they never have the vision to understand that it has to undergo regular curriculum revision cycles. That, like, you can't just throw it out there and go, here it is, buy this from our university, and you're cooking with gas and it'll answer all your problems. There's never a single right answer. It requires integration of multiple knowledges. So I think that that's one thing also, that we had a leadership in governance that went, we will never say we are the single right answer, and we know we have the answers to everything, because this is so complex, it's just not possible. Our vision is we will be the best education program in the world. Like that kind of statement is just, I'm saying this because it used to be what every organization would do in their visioning exercises. And we've learned since then that that's just silliness.
So it brings me back to thinking about your earlier statement around how do we kind of capture all the expertise in Gero nursing education, that cooperative education model that you kind of alluded to. Wouldn't it be lovely if we could take the work that Lillian does at UBC, that's done back east, that all of us are doing in our ways, and find some really effective way to share the wealth, share the knowledge, share the ideas, keep moving things forward.
Yeah, it seems to me that I think, CIHR needs to develop a side that if you have something like your robots and some of the projects that your students presented so beautifully at the CGNA conference, Lillian, I was so impressed. And I thought to myself, okay, I have a mother-in-law, a beloved mother-in-law, who's living in a long-term care home. And man, I'm a member of the family council. I would love to go to those guys, Lillian, because they have raised money to create some sensory simulation. Okay. And, I don't know, what are they going to do? They're probably going to go to, Snoozlin model. Oh my God. I don't know what they're going to decide. And I'm not saying that's not a bad program, but ultimately it is something that helps residents, these people, communicate with their family, for goodness sake. And if you're sitting in a room with what are those things? Ultraviolet cables that get sticky after a while, and you're looking at these sound tubes and stuff like that. Like, who decided that was what a snoozlin should be? I did a snoozlin project. It seemed like a great idea at the time, but now I think, oh my God, we did that at Shalom Village when I was the director of education and research there, and we got a great grant from the Ladies Auxiliary, the volunteer auxiliary, and we purchased all this stuff, and you brought people down and you interacted with groups versus single, and little journals that family members could contribute to. I think it always comes down to the fact that these are the means with which family members, staff, and volunteers interact with purpose with the person with dementia. But really, like even dementiability or the Montessori method, like how many times can you group forks, spoons, and knives, for goodness sake, like, and find them in sort of like little balls and that they're hidden, I'll just share a quick little story about how these things aren't always pragmatic or useful in the real world of people and what they love to do. We hired at St. Peter's a company that came in and wanted to create a wall mount that had wheels that people could turn and things to touch and little doors to open and all this sort of stuff. Okay, and we had a student from McMaster gerontology program doing a thesis, and Julie Richardson, who was the director of research at the time at St. Peter's, and I worked together, and we videotaped people interacting with this wall mount that was supposed to be the magic answer, okay? To a person. All 15 participants would sort of look at us, and they wanted to talk to us. They weren't interested in working this stupid thing on the wall sort of thing, right? And in fact, one person said, okay, so you want me to do this, but I want to talk to you. And I just sort of went, I don't know what this is all about. I don't know what the right answer is, but we're too much third party sort of objects on the wall that ultimately sometimes those research projects contribute to the notion that the human interaction is replaceable by something that it is not a person. So I'm aware that Yiska Cohen-Mansfield had family members recording messages that could be shown in videotape to people at their long-term care organization where she was doing all this research. And same thing, they weren't that interested in the static videotape. They wanted the live conversation, the interaction and exchange, and that's what your research has uncovered, is the positiveness of that. So to answer your question, we need some kind of federal funded, maybe through CIHR, that when you've got that kind of an idea, that your next level, once you have a prototype developed and with solid findings, you get an entrepreneurship grant that allows you to disseminate as broadly as possible from a pan-Canadian perspective. Because what happens with these great ideas, funding is needed to disseminate this kind of knowledge. That also will allow students to see this more, so that they will understand that this knowledge is actually transferable to other settings beyond long-term care, but also that it makes the long-term care setting or gerontologically specific healthcare settings more palatable and actually exciting to novice practitioners.
Yeah. Well, thank you for all those wonderful stories, and thanks for taking the time to talk with us. And if I may ask you the last thing, and what if you have the magic wand, what would be the thing that you wish that will happen that we can have, so that we can make gerontological nursing attractive to our young nurses?
Well, I think funding to the level of the World Health Organization with a very purposeful campaign. So, for example, that World Health or anti-ageist policy has got very specific messages, videotapes, marketing posters that I think would be useful for us to send to every single school of nursing, every single organization. Who does that collaboratively? I think that should be PHAC, Public Health Agency of Canada, with Ministry of Health, Ministry of Education, as well as cross-jurisdictional provincial leads, and of course, Canadian Nurses Association and CGNA, that we get this money and that we're involved together, and that the co-leads would be something like a triumvirate between CASN, CGNA, CNA, and a federal representative. Oh, how about this? Lee Chapman as the Chief Nursing Officer of Canada. Let's give her something to bite her teeth into that might be a little bit less overwhelming compared to some of the stuff that she's been tasked with, that I'm a bit worried that she'll actually be able to really get that stuff going.
Let's hope she listens to this episode. Let's hope she's a listener to Gero Nurses. So thank you so much, Lori. And we'd like to thank all of the listeners for taking time this afternoon. And if you can think of anyone that we should chat with on an upcoming episode of Gero Nurses, please email us at lillian.hung@ubc.ca or shelleycanning@ufv.ca.
And know that gerontological nursing is the most fantastic opportunity. The possibilities are endless.
Absolutely. So until our next episode, we hope you all stay safe, stay healthy. Remember, laughter isn't the best medicine. Medicine is. So talk to you soon again.
And that's the show.